don't know if this is my worst nightmare, but I do think it was a very interesting case worth presenting. So the patient is a 77-year-old male, past medical history of hypertension, coronary artery disease. He has some coronary stents and a known 5.7 centimeter abdominal aortic aneurysm. He presented to his cardiologist with fatigue and dyspnea on exertion. He was evaluated for syncope. As part of the workup, he had an echocardiogram, which showed a small valve area, and they determined that he needed a TAVR. So he was booked for the TAVR. This was all prior to any vascular evaluation. And this is his preoperative CT, which you see the infrarenal 5.7 centimeter abdominal aortic aneurysm. He had a fairly tortuous thoracic aorta, but otherwise it looks fairly normal. He has a bovine arch. Also of note, what you don't see on here, he has a replaced right hepatic artery off of the celiac artery. So he did go to the OR with cardiac surgery and cardiology. In the US, they do the valves together. And intraoperatively, they placed a 26 millimeter Sapien valve. Apparently, they had some iatrogenic type B dissection, which they fixed. We originally didn't have any details, and that involved placing a 12 millimeter by 80 millimeter smart stent in the right iliac artery. And again, this is before vascular surgery was involved. So we don't have a lot of images. I guess the cardiac surgeons did not take many, but on the left, you see the TAVR valve. On the second image, you do see a picture, which I believe is the aorta with the dissection. It looks like the true lumen. If you go the second to last picture, you see the stent being deployed and you can kind of see it. And that's really all the imaging that was done. He had a postoperative CAT scan. Again, this is well before vascular surgery was involved, and I'll let it run and I will go through it. So you see intramural hematoma with dissection in the descending thoracic aorta, very complex tears in that tortuous part. I'll see if I can slow it down. So it looks intramural hematoma. There's some flow in it. It should go down. It was very complex in that S turn. There were multiple tears, it looked like. And the true lumen down on the bottom of the chest CT was pretty small. One more look, and then we'll look at the abdominal CT. Again, small true lumen feeding most of the visceral vessels, and I'll come back around the perivisceral aorta. That's the celiac, the SMA with the replaced right hepatic off of the true lumen, which was small. That is the infrarenal neck with the renal arteries involved in the dissection. You see the true lumen on the right is very small through the aneurysm. I guess at that point they measured it at 5.6-ish. And as you come down, you see the stent they placed, which is kind of in the lower third of the aneurysm and goes into the right common iliac artery. And you see the dissection involved in the left iliac artery there. Obviously, that starts to complicate if he needs his aneurysm fixed, that he has a bare stent sitting in the middle of his aneurysm there. Just some more images. Here's a coronal view with the stent they placed from the right iliac in the aneurysm, and some other views with the true and false lumen. And you see the infrarenal neck with the involved in the dissection. So while walking to work one day, I bumped into the cardiac surgeon and he curbside consulted me and said, I'm sending you a patient with a small type B dissection. I think he needs his abdominal aneurysm fixed. I said, okay. I told my office to schedule him in a few weeks, not knowing all the details of the procedure. The patient then started having progressive back pain, postprandial pain, which he apparently had from just after the procedure, and this is about 3 weeks out. I got a call from the daughter. He can't eat. He feels extremely weak and tired. And then the same day, the nurse practitioner that works for cardiac emailed me and said, you have to see him as soon as possible. I said, okay, get him in. Let's repeat the CT and I'll evaluate him. So the CT now, if it will play. Let me see if I can go through it. It might be easier. The intramural hematoma is still there. You don't see any tears up top, but you do see, it looks pretty similar here. Again, the complex tears throughout that bend. The true lumen, though, as you go through the superior mesenteric artery, it's celiac. And the SMA, I'll try to go back to it. The true lumen is extremely compressed, probably accounting for his not being able to eat. And if we look at the abdominal, again, small true lumen. That's your neck and your aneurysm. And the stent going down. So we brought him into the office. I examined him. He was extremely debilitated, could barely walk. He lost about 20 pounds since the TAVR. He looked kind of pale. He did have drossalus artery pulses. His abdomen was not tender, although he said he hasn't eaten in a while. So we admitted him straight and booked him for the operating room to try to do something under local anesthesia. Based on the CT, we thought we would have to cover the left subclavian. We would like to revascularize it since that'd be extensive coverage. So we planned a left subclavian snorkel, a TVAR to cover all those tears around the bend, the Cook Bear metal dissection stent to extend down and open the perivisceral aorta, with a plan to land somewhere around the SMA to leave the area between the renal arteries and the SMA open in case we needed to clamp it in the future to do an open repair of his abdominal aortic aneurysm. So here are some intraoperative images. Again, under local anesthesia, we got bilateral groin access and left brachial access. Here you see the left brachial access in the first picture with an Omni catheter trying to direct the wire from above in the true lumen. And then we came from below, try to find the true lumen. And there were so many tears, I think it took us over an hour to come from above and below and try to picture the true lumen and false lumen and meet and stay in the true lumen the whole way, which is obviously important. This was, I think, an image before we were able to do it and snare the wire. You can barely see the true lumen. We had a glide advantage wire from below. We had a long glide catheter from above, and we were finally able to track that wire through the true lumen, snare it, and get what we thought was in true lumen completely around from the groin up to the ascending aorta. Of course, then we put IVUS through. Here's the thoracic aorta to make sure the IVUS is in the true lumen the whole way, and indeed it was. We then brought up a Gore C-tag from the groin. I believe we used the right groin, the one through the stent, and we put a VBX stent in place, ready for the snorkel, planning to land right at the left subclavian artery. This is the partially deployed Gore C-tag. It was the conformable. This is completely deployed. It's hard to see, but right at the subclavian. And then we did an injection to make sure that we were proximal to the left vertebral artery with the snorkel. And again, one more high level fluoro to make sure that we were at least 1 centimeter out from the fabric for the left subclavian snorkel. Again, we thought this was important for spinal cord perfusion. This is deployment of the